Today is basically orthopaedics related to tennis, which I suppose is appropriate. Back pain in tennis is a funny topic because really it's the same as any other sport. The same kind of things happen in a slightly different frequency. As with all sports, the type of injury you get tends to relate to the type of movement that you undertake while you're performing that sport. Virtually no tennis-related back problems are surgical. They're almost all treated by rehabilitation. Same for everything to do with back pain. Just because they're playing a sport, whether it be amateur or whether it be high level, with back problems in particular, it's difficult to get a straight answer as to what's wrong with you. It's important for the patient to have clarity. Sadly, not only is there not much evidence-based practice, there's a hell of a lot of evidence that what's done doesn't work, doesn't seem to stop us doing it. Now, exercise. We tell people to exercise all the time, and it's for good, but also it does cause issues. Now, red flags. Don't apologise for this. Just because they're playing sport, just because they've got back pain, doesn't mean you don't consider the red flags. It is the first thing you consider when you see anybody with back pain. The red flags, think about it. I have picked up professional sportsmen with significant conditions, spinal tumours, variety of other things, transverse myelitis, for example, in a professional sportsman. So these things do get picked up. We need to. If you don't pick them up, you will regret it. Common things happen commonly, even in sportsmen. Now, this is my experience. This is just over the last 2 years to give you some idea of the presentation of different sports in my practice. And here we got tennis. So it's actually reasonably frequent that you see people who play tennis and have back problems. Here I'm referring to people who have back pain that is probably related in some way to their playing the sport, not just people who have back pain who happen to play tennis. So it's reasonably frequent. This is how the pie slices up with the different levels of ability. This is over, I suppose it's about 8 years now, so this amateur slice of the pie represents about 450 patients, all the way through to the to a professional side here, which is only 8. So very small numbers with significant back problems. And this is how it slices up with regard to causation. So facetogenic pain, well, it's a sport that involves rotation and extension, both for overhead shots, for high backhand shots, a lot of rotation. So it's not surprising that the facet joints take a pounding. And I think you could safely say that pretty much all tennis players, by the time they get to adulthood, have abnormal facet joints. So the key is obviously, is it the cause of their pain? Here I'm saying they have facetogenic pain, not they've got an MRI scan showing a dodgy facet joint. Disc issues are common in everybody, so they're common in tennis players as well. Pars issues, common in tennis, more than they would be in football or rugby, less than they would be in gymnastics or in ballet, but still they happen. So spondylolysis. Now, although spondylolysis isn't the commonest cause of back pain in a tennis player, because it's an acute bony injury that does need specific treatment, it is one that should be thought of. And it's the same with any sportsman. Any sportsman with an insidious onset of back pain that's persistent and activity related should be considered to have a stress fracture until you've proven otherwise, even though it's not the most likely thing that they have. The risk factors for getting a stress fracture, and this harks back to other talks, it's a combination of structure, function and demand. How are you made, what are you doing, and how much are you asking of your spine? And it's a combination of those. Is it an orchestra where everyone's playing the instruments very well, but everyone's playing different music? You know, do you coordinate your core control, your pelvic movement? Are your hamstrings working properly in combination with your lower back? So it's functional patterns of movement. And tennis is a sport, probably more than many others, where it's the functional pattern of movement that's really vital. And that's the thing that you'll all spend a lot of your time working with patients on. So the risk factors for spondylolysis, you've got disproportionate upper body strength with poor gluteal strength. Doesn't apply to professionals, really. I mean, of all the sports that I've ever had anything to do with professionally, the tennis players are by a country mile the fittest. Their level of training intensity and their general level of fitness is massive in comparison to professional footballers, whoever you like to talk about. Really, really hugely strong. But the vast majority of the people we see are obviously the people who play tennis at the weekends. It may be very important. You'll see somebody who plays for relaxation, but they'll play 4 or 5 times a week. So it's significant stress on their body. So, and repeated submaximal forces. So that constant rotation and extension, rotation and extension, rotation and extension until something breaks. Now you can modify the workload in cricket, as it was discussed at a previous talk. If you restrict the number of overs that the youngsters bowl, and that massively reduces the likelihood of them having a stress fracture. The problem with professional tennis is, they'll play 4 days in a week. Each game could last 3 or 4 hours. They'll train on the other days, they'll fly somewhere else, and they'll do exactly the same thing. And they'll play for 48 weeks a year. There aren't many sports that do that. Football certainly doesn't. They'll train 3 times a week and play once, maybe twice, and complain if they play the second time. The tennis players, their intensity is incredible. But obviously amateurs, again, can overdo things. So the diagnosis. Well, you've got these things up in the air. What may they have? Well, facet joint pain is something you're going to think about. Spondylolysis, disc issues, red flags. As with everything else, the diagnosis is made before you scan the patient, if you're going to scan them. It's on the history, it's on the examination. Now, facet joint syndrome, it's a clinical diagnosis. We all know what it is. You wake up in the morning, you've got a stiff, achy back. It takes time to be able to brush your teeth. Extension's uncomfortable, rotation's uncomfortable. It improves as the day goes on and gets worse towards the end of the day. Doesn't tend to be worse when you sit, but it's worse when you get up when you have been sitting. That sort of pain radiates into your buttocks and into the posterior thighs. Spondylolysis tends to be a more gradual onset, and you think about it in somebody who has a tennis stroke or a level of exercise that makes it more likely. Examination, one-legged hyperextension. When you stand on the affected side, hyperextend and rotate, so it locks the pelvis, and that can often reproduce their symptoms. Now, so examination's key. Investigations. Plain X-rays, don't tend to use them. We'll come along to something about imaging in tennis players in a moment, but it's radiation. If you take an X-ray of somebody who plays a lot of sport, if they play a lot of sport, they won't have a normal X-ray. If they play a moderate amount of sport, but they've been doing it for any length of time, they won't have a normal X-ray. And they could be symptomatic or asymptomatic. So it's radiation without information. And I don't think we should be doing it. MRI scan. Now, we'll come on to MRI in a minute. And then we move through bone scans, SPECT CT, and more invasive investigations. X-rays are cheap, accessible, but they can often be misleading. MRI scan. Now, MRI scan seems great because it's quite available now, provided you can pay for it. No radiation involved, seems like a great idea. Good paper that by Alias et al. In the British Journal of Sports Medicine quite a few years ago now, looking at 33 adolescent elite tennis players and scanning them. And as you can see, only 15% of them had normal MRI scans, and these are adolescents. They're asymptomatic. So, you've got pars lesions, you've got spondylolisthesis, even up to a grade 2 spondylolisthesis. 2/3 of them had facet joint degeneration. And that's in an adolescent, facet joint degeneration in an adolescent, that's not normal. You scan 100 adolescents, you're not going to find facet joint degeneration in many of them at all. So tennis obviously loads your facet joints. But what is degeneration? If you scan or you X-ray somebody and they've got an enlarged facet joint, that's not degeneration. That's the facet joint dealing with the load that they're putting through it. How do you spread the load? Well, you spread the force over a wider area. How do you do that? You make the joint bigger. Well, the joints are living things. So if you keep loading your facet joints at L4-5 on the right-hand side because you're a right-handed tennis player, the joints will get bigger. So that's not really an abnormality in a tennis player. It's abnormal if it's lost cartilage, if it has significant fluid in it, or if it shows up high signal on an MRI scan. So got to be careful. Synovial cysts, well, I mean, you definitely say a synovial cyst's abnormal. I mean, that's, so much fluid in the joint, it's formed a cyst outside the joint. But 1/3 of them in adolescents who had no pain. So it can be really misleading. So here's just a couple of examples. Here's very intense pars pedicle stress reaction showing up high signal here, low signal on the T1 weighted images. Showed up on a bone scan. Now bone scans, lots and lots of x-rays a bone scan, the equivalent amount of radiation, so wouldn't be your first line of investigation. Now if you've got an adolescent who plays a lot of tennis and they've got back pain and you think it could be a stress fracture, and you take an MRI scan and, well, it could be a stress fracture, and you take an x-ray and it could be a stress fracture, this is sort of a biological investigation. It will show if there is significantly abnormal biology going on, if the blood supplies increase there. So that may be significant. SPECT CT is up to 500 x-rays if you do a lumbar spine SPECT CT. So that's a hell of a lot to do, especially if you're talking about adolescents. So you'd only use that if you're actually going to do something about it. So the most important thing with treating these is prevent it happening in the first place. Do more of the right thing. I ask everybody, as I'm sure you do you play any sport? Do you do any exercise? Yeah, I play tennis at the weekend. Do you do any sport? You play tennis. Do you do any exercise? Yeah, I play tennis. No, you don't do any exercise. That doesn't count. Do you do any strength and conditioning? Do you do anything to make yourself fit enough to play? So you train to play, you don't play to train. A lot of people don't. And when you're 20 and a teenager, you don't have to do any exercise, any strength and conditioning really, unless you're elite level. You can just play. You're bendy, you've got that innate muscle flexibility, so you get away with it. As you get older, you should be doing more and more strength and conditioning. Whereas what actually happens is, as people get older, they do less strength and conditioning and they rely on the sport to keep them fit, which is entirely the opposite of what they need to do. Take good advice. Well, obviously get some good coaching. If you play tennis, you are doing the same thing repetitively, so it's important to do it the right way, otherwise you are going to injure yourself. Horses for courses. You know, maybe you're not made to be a tennis player, maybe you should be doing something else. So you need to think about that. Just because you want to play a sport doesn't mean you can. And the treatment of the athlete is rest. If somebody has back pain that's brought on by playing tennis, don't play for a bit. You know, it's one thing if you're getting paid £15 million a year to play, but if it's just something you do at the weekends, go and do something else. Get in a swimming pool, walk, get on a bike, allow your body to heal. It's amazing the number of people who go through all of us. They go through physio, chiro, osteopathy, GPs, painkillers, God knows what, and they'll come and see me, and they haven't actually stopped playing. I'm not talking about don't play for the rest of your life, just let the injury heal. Anyway, discogenic pain, less common as a presentation in tennis players, but as common as it is in anybody else. Treated the same way as it is in anybody else. Moving through, this is facet joint degeneration on an MRI scan. There's a facet joint there. If you look at a normal facet joint, abnormal facet joint is enlarged and irregular. But again, is that the cause of pain? Well, it might be if the rest of the investigations and the rest of the examination makes you think that it is. Now, you also get unusual causes of pain. This is a peculiar thing. This is a chap who presented with thoracic back pain, worse on rotation, which is very common in people who play sports, because as people get older, obviously their thoracic spine is less mobile. And if you have back pain and you go to a therapist, they'll mobilize your thoracic spine, because it's too stiff, because all our thoracic spines are too stiff, so that's how you make it better. But it isn't if you've got DISH, if you've got disseminated idiopathic skeletal hyperostosis. Basically, you've got osteophytes bridging your vertebral bodies in your thoracic spine. Well, that's why it's stiff, and mobilizing it isn't going to work. And quite an unusual cause, but here, I mean, he's effectively developing a bamboo spine, which shows up very nicely on a SPECT CT scan, because it's quite an unusual cause of pain. But you can see there, that really lights up. That's the cause of the pain. And the treatment for that is rest. You're not going to go in and excise that osteophyte through their chest. It's just to rest. Facetogenic pain, probably the most common. How do you manage facetogenic pain in a tennis player? Well, obviously you rest. You make sure they're playing properly, you make sure their core is working properly, you make sure they're flexible enough, you build up through functional rehabilitation functional movements, moving more than one joint, more than one part of the body at a time, working on rotation, all very important. If that doesn't work, then we can move on to more invasive treatments. Tennis player, not professional tennis player, amateur tennis player with low back pain. No other symptoms and an enormous disc prolapse, huge, with cauda equina compression, but no other signs or symptoms whatsoever. So these things can happen to anybody, and that's the disc fragment that's taken out. That's 5 centimetres. That's enormous. So treatment, pain relief, you work through the normal things. This is just referring to the treatment of spondylolysis. I'm not going to go into it in detail, but basically it's rest, rehabilitate, analgesia, and operate only if you have no choice. So you stop exercising. Once the pain's settled, you progressively rehabilitate, and you use your rehabilitation time carefully. Epidural steroid injections are not a magic cure, they just make the patients feel better to enable them to rehabilitate properly, so they're worthwhile. Facet joint injections, exactly the same. Radiofrequency nerve ablation can be quite useful and keep people going. If you have somebody whose job involves them playing tennis, for example, then buzzing the facet joints and keeping it pain-free may be what needs to be done, and it may need to be done frequently. Coblation, again, this is, you see, when professional sportsmen have issues, nobody wants to operate on them, and I certainly don't want to operate on them, so you try anything short of surgery, and coblation is one of the things that people try, and it's basically trying to cook the disc from the inside to get it to shrivel up if you've got a disc prolapse. Seems like a good idea, but it doesn't work. This is what I'm talking about, the kind of functional movements, rotation movements. What are you going to do when you play sport? So let's rehabilitate you doing the things that you're actually going to need to do. You know, doing the plank and the sort of Superman and more sort of classical Pilates type movements is great, but it's really not going to help you when you get back on a tennis court. You need to have those movement patterns ingrained whilst you're moving, and you haven't got the time to think about the way that you're moving. So that's the way forward. And the return to play is you use your time wisely. Am I playing correctly? Get some coaching. Look at your orthotics. How do you move? Maybe get a running coach. It's amazing, people play tennis and it actually involves a lot of sprinting, and nobody's ever looked at the way that they sprint. You know, going for a jog for 10 miles isn't going to help you running around a tennis court. So that's one thing to do. Further radiology, you'd only investigate people really if they're not settling. Surgery, last resort, absolute last resort. I know I'm putting myself out of business, but you know, people who play sport to a decent level need to avoid surgery unless they haven't got a choice. The thresholds obviously changed depending on how important it is for them to get back to their sport as quickly as possible, but you'd still try and put people off. Repairing spondylolysis is not a great thing to do. Often the repairs fail, the screws break, and you end up with more pain than you started off with, and it takes, after a spondylolysis repair, up to a year before you can return to sport. If you hadn't played sport for a year, you'd have returned to sport anyway, so I wouldn't advise it. Pain is normal in elite athletes. All elite athletes deal with pain all the time. It's how they manage it and whether it's outside of that envelope of normality for them. The vast majority of people need conservative management. Diagnosis is mostly clinical. Imaging is often misleading, but can still be useful. Do little to them. We're all supposed to be helping people recover themselves. Remember that the function, what they're aiming to get back to and what their aspirations are. And sometimes it involves telling them, you can't do that, you need to do less, or have a lower target. Often, you know, someone needs to have a conversation and say, look, you know, if you're going to play tennis 6 times a week, you're going to end up playing nothing. So pace yourself, mix your sport up, do more than one thing, and that'll be the best thing for you. And rehab is king. Thank you.